My name is Naveen Pemmaraju. I'm an Assistant Professor of Leukemia at the MD Anderson Cancer Center in Houston, Texas. I had the opportunity to attend and participate in the ASH meeting. Today, I'd like to update all of you on the exciting and new developments in the world of chronic myeloid leukemia, or CML. To do this, I would like to highlight several key abstracts in major categories, including treatment discontinuation, extended use of tyrosine kinase inhibitors, and the treatment of adolescent young adults. The first abstract by Dr. Clark and Dr. Coughlin and colleagues from Great Britain, and it dealt with CML patients with stable molecular responses who may safely decrease the dose of their tyrosine kinase inhibitor. This data was presented from what's called the British DESTINY study, and is really based on the principle that was started by multiple European groups, but actually adds a key element, de-escalation phase of the TKI, which then led to actually stopping it. So in this study, patients with CML were de-escalated when they were already on a stable dose of their tyrosine kinase inhibitor after approximately 1 year, and then went to actually stopping it. Over the period of 2 years, 174 patients were recruited in this multi-center study all throughout Great Britain. Most of these patients were on imatinib, with 16 and 10 patients respectively on second-generation inhibitors, nilotinib and statinib. The key finding from this abstract was that in CML patients with stable molecular response, termed MR3 or better, that decreasing the TKI treatment to half of the standard dose that they started on appeared to be safe in quite a few of the patients. This was also associated with an improvement in the TKI-related side effects, and that it meant that there are a subset of patients with stable responses who may be able to benefit from treatment de-escalation and ultimately stopping treatment overall. And the conclusion is that more studies such as this, with de-escalation ultimately stopping, are warranted to further validate these findings. Now, the second abstract I'd like to highlight was by Dr. Francois-Xavier Mahon and colleagues. This abstract was entitled Cessation of Tyrosine Kinase Inhibitors, Treatment in CML Patients with Deep Molecular Response, Results of the EURO-SKI Study SKI trial. Some patients with CML who have been doing well on a stable dose of their tyrosine kinase inhibitor and have achieved what's called a DMR, or deep molecular response, some subset of these patients may be able to stop treatment after some point. A quite large number of patients, 821 patients with chronic phase CML, were recruited to this study over just 2 years, all throughout Europe, 11 European countries. Notably, the key finding was that molecular relapse-free survival at 6 months was 65.5% for those treated on imatinib greater than 5 to 6 years, and 42.6% for treatment in those patients less than 5.8 years. One of the more interesting findings of the study was that the group included a pharmacoeconomic analysis. They estimated that the total savings could amount to over 27 million euro for those patients who are able to stop imatinib therapy earlier than others, meaning cost savings to the healthcare system. And finally, in this study, that longer duration of imatinib therapy, in this study, the statistical cutoff was greater than 5.8 years prior to the stopping of the TKI, was associated with a higher probability of this molecular recurrence-free survival, or MRFS. Now, this takes us to the next study conducted by Dr. Andreas Pakas and colleagues. This abstract focused more on quality of life, that is, patient-reported quality of life, or QOL, after stopping treatment on a TKI and following patients with a prospective validated survey approach. This study was conducted in the ENESTfreedom Study, which is an ongoing phase 2 trial evaluating the potential for patients to stop therapy with their TKI, which in this case was nilotinib. Just for background, the initial results from the ENESTfreedom, according to the abstract, showed that 51.6% of patients who attempted this TFR, treatment-free remission, remained off treatment without the loss of major molecular response, or MMR, at 48 weeks. I thought there were 2 important points to highlight from this. First, the existence of validated tools in CML, as well as other chronic diseases. For CML, the MD Anderson Symptom Inventory, or MEDACI CML, was used along with another study called the EQ5D5L questionnaire. And the second point is the results were quite compelling. Among 215 patients enrolled, The investigators found that 190 patients remained in sustained DMR, or deep molecular response, during the consolidation phase, and they entered into this treatment-free phase. So in conclusion, they stated that minimal changes in patient-reported outcomes were observed after stopping treatment, and that this may be related to patients having either a relatively high quality of life before they stopped the treatment in the first place, given that they were already stable for 2 years or more on their nilotinib. And it also suggested that there was a signal for higher frequency of musculoskeletal pain-related adverse events, even when patients entered in the treatment-free phase, although this did not substantially affect or impact patients' overall quality of life. Now we turn our attention to another abstract that was of importance at this year's ASH, and this was conducted by Dr. Fiorina Giona, our colleagues from Italy. In this abstract, entitled Management of CML in Children and Adolescents According to Local Guidelines, the Italian Experience, the investigators put forward a very thoughtful look at patients, especially focusing on outcomes in adolescents and young adults in CML. This abstract is important as it highlights that before the year 2000, allogeneic stem cell transplant was actually the only potentially curative treatment for children and young adults with CML in the chronic phase. But since that time, there's been a revolution in the treatment of CML, including the inclusion of second-generation tyrosine kinase inhibitors and other treatment options. So in this study, 57 patients with CML with a very young age as compared to most of our series, a median age of only 11.4 years, were included, and they were followed between 2001 and 2015, so quite a long follow-up time. These patients were managed and treated at a number of different centers, and all but one patient, 50 out of the 51 patients, achieved a cytogenetic or molecular remission, and 7 of the 50 responders, or 14%, actually underwent a stem cell transplant from an HLA-related or matched unrelated donor. This is all before 2009. Importantly, 11 patients were rescued with second-generation TKIs. Those are patients who were losing or had lost their response to imatinib. 5 patients restarted continuous imatinib, and 2 patients underwent a transplant from a matched unrelated donor. Of importance, all 57 patients analyzed were alive at a median follow-up of 72 months, with a range anywhere from 12 to 184 months. Next, we turn our attention to a very compelling abstract by Dr. Ria and colleagues, which is entitled the ENESTPath, a phase 3 study to assess the effect of nilotinib treatment duration on treatment-free remission in patients with CML. This study is one of the larger studies in the field of CML, as it involves a phase 3 randomized study, and it focuses on a second-generation TKI called nilotinib and patients who are able to stop therapy. Patients with CML chronic phase who have achieved a chronic cytogenetic response, but not yet achieved the fullest, deepest molecular response, an MR4, after 2 years or more on imatinib, are included in the study. Those patients are then go into 2 cohorts. One is that they go into the treatment-free phase immediately, so they go off of therapy. Or in a second cohort, they continue nilotinib for another year and then go into the treatment discontinuation. Importantly, these patients at that point are in a stable molecular remission. A very large number of patients have been enrolled in the study, 619 in total, of which 300 patients are now available for this first interim analysis. There are 2 key findings. One is that in this first 300 patients, after 2 years of nilotinib therapy, there's a cumulative incidence of MR4, or deep molecular remission, in approximately 70% of patients who were not in molecular remission at baseline. The second important finding from this is that the majority of the adverse events were low grade, and the most common adverse events, notwithstanding the relationship of the study drug, were manageable side effects, including itching, hypercholesterolemia, rash, asthenia, and arthralgias. Finally, we turn our attention to one last abstract presented by Dr. David Young and colleagues from Australia. In this abstract, entitled Upfront Imatinib with Selective Early Switching to Nilotinib Leads to Excellent Achievement of Deep Molecular Response in CML, this 5-year analysis was conducted of the TIDEL-II Study. And so the background of this was that patients were treated with upfront imatinib with a selective early switching strategy to the second-generation TKI nilotinib, and they were already known to have an excellent deep molecular response for this cohort. There's 2 important and interesting key elements to this abstract. This is one of the few approaches that you will see that has a higher starting dose of imatinib than the traditional 400 milligrams in most studies. So in this study, patients actually began at a dose of imatinib 600 milligrams. One arm was that the imatinib, if there was not an optimal response, was increased to 800 milligrams of imatinib, and then patients were switched to nilotinib. Or in the second arm, patients were switched to nilotinib directly in the setting of suboptimal response. So the study overall enrolled 210 patients, and what the investigators found was that out of 181 patients achieving MMR on study, 24% or 44 did so after switching to nilotinib. The combination of imatinib and nilotinib appeared to compare favorably with other upfront treatment strategies, with MR 4.5 of 59% by 60 months. And so with this, I'd like to conclude by telling everyone out there, thank you very much. These are the highlights that I saw from ASH with regards to our patients and research in the field of chronic myeloid leukemia, and I look forward to 2017 for more breakthroughs for our patients. Thank you very much.